Hello and welcome to ESDO LearningBytes. My name is Zineb Benbrahim, Professor of Medical Oncology in Hassan University Hospital in Fez, and today's topic is cancer-related fatigue or CRF. It's a topic of particular interest. We know that it's commonly experienced by survivors of cancer through all stages of the disease, with up to 40% of patients at diagnosis and 80 to 90% of patients during chemo and radiotherapy. It's important to know that cancer-related fatigue is different from the fatigue of daily life. It's more severe, more distressing, and may also impact prognosis. So in clinical studies, fatigue at diagnosis and during survivorship was associated with higher mortality. But how can we define fatigue? Actually, there is no universal definition of CRF across scientific communities, but according to the NCCN, it's a distressing, persistent, subjective sense of physical, emotional, and/or cognitive exhaustion related to cancer or cancer treatment. It's not proportional to recent activity and interferes with usual functioning. So on the basis of this definition, it's clear that there are multiple dimensions of CRF. And evidence suggests the involvement of complex, multifactorial processes linked to a range of physiological, clinical, and psychological factors like activation of the peripheral pro-inflammatory cytokine network, stimulation of the hypothalamic pituitary adrenal axis with alteration of cortisol levels, or damage of the mitochondria after chemo or radiotherapy. Now let's have a look on the assessment of fatigue. From the point of diagnosis, every patient should be screened for fatigue presence and severity. We can use the numeric rating scale, and the score of 1 to 3 indicates mild fatigue, 4 to 6 moderate, and 7 to 10 indicates severe fatigue. Beyond, there are many valid and reliable quantitative instruments available, like the Piper Fatigue Scale, the BFI or Brief Fatigue Inventory, and the EORTC Core 30 Fatigue Subscale. And it's important to know that screening is not a one-time experience, but should be conducted at regular intervals. Okay, so after assessment, additional interventions may be introduced, like physical, psychological, and sometimes pharmacological interventions, and in many situations, the combination of approaches must be used. So let's start with this last one, the pharmacological intervention. Actually, many studies showed interest in the use of some dietary supplements for the management of CRF, but clinical trials and systematic reviews found no effect of L-carnitine, coenzyme 10, and guarana on fatigue survivals. And based on this, ESMO do not recommend the use of these supplements for CRF reduction during cancer treatments. Samely for ginseng, a systematic review concluded that regardless of type, it seems to have only modest efficacy in reducing fatigue. So for ginseng use, the ESMO panel has not reached a consensus. For some panel members, extracts of Wisconsin ginseng could be considered in the absence of the other treatable reasons and where the fatigue lasts at least 4 weeks during active cancer treatment, but for the other ESMO panel members, it cannot be recommended. What about pharmacological interventions? Obviously, erythropoietin can be effective in improving fatigue if associated with anemia during active cancer treatment. For methylphenidate, it was superior to placebo in some studies. The caveat here was sleep problems or decreased appetite, where results from meta-analysis indicate modest efficacy. And the same meta-analysis concluded that neither modafinil or corticosteroids are associated with reduction in CRF. So what does the guidelines say? Short-term use of corticosteroids is recommended for the control of CRF in metastatic cancer patients. The use of psychostimulants could be considered in selected patients, and their usefulness and safety should be evaluated after a very short time period. Okay. Let's move to exercise as one of therapeutic interventions for CRF. And the take-home message here is when comparing the efficacy of pharmacological, psychological, and physical interventions, exercise shows the greatest effect. Mode of exercise is not associated with effectiveness, so ESMO recommend physical exercise of moderate intensity in non-cachectic patients with cancer-related fatigue. Psychosocial interventions for treatment of CRF cover a broad range of various interventions such as mind-body interventions, psychotherapy, or psychoeducation. And the main goals of these interventions are to help patients change their coping strategies and behavior and address self-help or self-care strategies. Some interventions such as relaxation techniques and yoga are the most effective in reducing fatigue during cancer treatments. Also, cognitive behavioral therapy and mixed modal interventions delivered after completion of active treatment have been shown to be effective in reducing post-treatment fatigue. So for ESMO, mindfulness-based stress reduction, yoga, cognitive behavioral therapy, and psychoeducation are all options to improve CRF with different levels of recommendations. Hence, in mild to moderate fatigue, we should promote access to programs targeted to self-management of fatigue, and in moderate to severe fatigue, we consider interventions to support symptom management, including cognitive behavioral therapy, energy conservation, psychoeducational therapies, and other psychological interventions. So in conclusion, cancer-related fatigue is a distressing and frequently untreated symptom for many cancer patients. Many recommendations and guidelines exist, and according to these guidelines, the most effective treatment is physical and psychoeducational interventions, and of course, more specific research on CRF is needed in the future. Thank you for listening.